So I guess let's get started. So welcome everybody, and thank you so much for joining us for this webinar today, introducing the phosphate absorption inhibitor, a new treatment option with patients with CKD on dialysis. I'm Dr. Susan Murray, and I'm going to be your moderator for today. So we have a really great panel of speakers coming for you today, as you can see on this slide. So we're getting a lot of different perspectives. So two clinicians, we have dietitian, we have patient advocate, who we're very, very grateful to have here today. A few housekeeping things before we start. We will be answering your questions. We'll be handling all questions at the end. But if something crops up, if you could think of something, just pop it into the chat and we will get to it as we come to it. And after this talk, NKF staff are going to be circulating a survey, and that's going to be in the chat, but it's also going to be by email. And we would really, really appreciate that you gave us any feedback about this presentation and what you want to know and how we can improve. So here are our financial disclosures. As you can see. And here are our learning objectives for today. And they include describing the current state of hyperphosphatemia in CKD, summarizing the pertinent pharmacological characteristics in phosphate-lowering therapies, and discussing the important elements considered when initiating phosphate absorption inhibitors. This activity, so we just want to thank our sponsors. So this activity was sponsored by a grant from Dialysis. So just to have full transparency, we would just want to thank Dialysis for their partnership. But this talk was completely developed by the speakers today, and there wasn't any input from Dialysis. So much so they had spelled it out for me so I don't mispronounce it. We want to remind you that this is not an accredited CME talk, and so no CME credits for today. And with that, let's begin our program. So Brandon, I'm going to come to you first to talk us a little bit through what the current guidelines say about managing hyperphosphatemia in patients with CKD on dialysis.
Yeah, so thank you so much, and thank you to the National Kidney Foundation for the opportunity to participate in this webinar today, and especially to Andrew for doing everything to sort of make this a reality. So to answer your question, Susan, there are a number of guideline statements related to hyperphosphatemia management. In the sake of time, I've tried to pick just a few of the most relevant to our discussion today, starting with this idea of monitoring. And so if we think about the 2017 KDIGO guidance, they do provide, I see my reference has disappeared in the white background here, but these are the 2017 KDIGO CKD MBD update, and they do provide guidance for when to begin monitoring and the frequency. And so if I can draw your attention just to the middle bullet point here, it's reasonable to base the frequency of monitoring on the presence and magnitude of abnormalities, and it's reasonable to increase the frequency here in the bottom bullet point based on people receiving treatment for CKD MBD. And they do later in these guideline statements outline that a reasonable time frame may be 1 to 3 months. If I could go to my next slide here, yep. And so what are we doing with those measurements, or what are we looking for when we measure phosphate? Well, that's kind of evolved over time, as you can see on this slide here. This is from Joyce Virgili, a paper that's in press in the Journal of Renal Nutrition. And you can see at the top here, the 2003 KDOQI guidelines outlined this target of 3.5 to 5.5 milligrams per deciliter. And over time, that's evolved to this language that includes the normal range. And so you can see here on the right, that normal range is intended to meet the standard reference range, which can vary, but is generally 2.5 to 4.5 milligrams per deciliter. However, the point of this paper was actually to outline an issue that we ran into in a study that I was a part of, the AUGMENT study, which was looking to study the implementation of the 2020 KDOQI nutrition guidelines. In that study, one of the things we observed was that dietitians participating in that study almost unanimously chose values of 2.5 to 3 milligrams per deciliter as being low, and 4.5 to 5.5 milligrams per deciliter as being within the target range. And so this would suggest that even though these guidelines are outlining this normal range of 2.5 to 4.5 milligrams per deciliter, that at least some practitioners are currently using targets of 3 to 5.5 milligrams per deciliter. If we advance, we start to talk about what to do with treatment. And this idea that treatment for CKD MBD should be based on serial assessments of phosphate and decisions about phosphate lowering treatment made on progressively or persistently elevated serum phosphate. So sort of de-emphasizing these individual single measurements. The next slide focuses on some specific treatments. So this idea of limiting calcium-based phosphate binders and avoiding aluminum-containing phosphate binders or dialysate aluminum contamination. If you want to go to just the next slide after this one, I suspect that we have a lot of dietitians in the office or in the audience, and so I suggest that this might be of particular relevance. Recommend limiting dietary phosphate intake, and what more recent guidelines have seen is this idea that it's reasonable to consider the source or the bioavailability of the source in the case of the most recent KDOQI nutrition guidelines. And then one kind of tag on bullet point here, we focused a lot on trying to limit what's going in terms of phosphorus and phosphate. One final guideline here at the end is this idea of trying to increase dialysate or dialysis phosphate removal. So I'm actually a couple of slides ahead, Andrew, if you're... Yep, dialytic, so, and limiting or increasing phosphate removal from the dialysis procedure. So I'm all set.
No apologies for the technical difficulties, folks, but we might just move on and ask Sagar, and this is something I worry about a lot. But what does the data say about how we're doing about hyperphosphatemia management right now?
Yeah, thank you, Susan, for that question, and also thank you to the NKF for this invitation to share my thoughts. March is a National Kidney Month, so happy National Kidney Month to all of you, and also today happens to be the National Doctors Day, so for those who are doctors, happy National Doctors Day as well. So I think this is an important question, and I think, I will give you answer to that question from maybe a couple of different perspectives, a couple of different data sets. So DOPS is a large data set that many of you may be quite familiar with. This is an international prospective study of dialysis patients, both hemodialysis as well as peritoneal dialysis, who are in the adult age group. And the study population is randomly selected from a sample of dialysis facilities within each country. And the investigators collect demographic as well as the clinical data as it pertains to different comorbid conditions and medications. And these are collected at the time of study entry. And in addition to that, the data on laboratory parameters like phosphate, PTH, calcium, as well as the prescribed medications are also abstracted from the patient's baseline and then at subsequent follow-up regular intervals. So next slide, please. And so when we look at the DOPS database, and this is one of the recent publications that just highlights the overall proportions of dialysis patients who are staying within the different categories of serum phosphorus, for example. So here what I have on this slide is data from the DOPS, but only restricted to chronic hemodialysis patients. And these are also looking at patients just from the dialysis units in the United States. And on the x-axis, you have years going from 2013 to 2021. And on the y-axis, you have percentage of patients. And then the proportions of patients in the different categories of phosphorus control are categorized in different colors. So for example, the light blue is individuals with phosphate level or phosphorus levels below 3.5, orange is 3.5 to 4.5, dark blue is 4.6 to 5.5, then light gray is 5.6 to 7, and then green is more than 7. And I think the main point from this slide is in the title of this slide. Like 70% of these in-center hemodialysis patients in the US have mean serum phosphorus levels that is more than 4.5. And if we go by, as Brandon was suggesting, laboratory levels are typically upper limit of that normal range is 4.5. So majority of the patients are staying above that range. And the other point is, is on the next slide. Thank you for advancing. Is year after year. So now this paper is looking at the trend in the phosphorus control over the last, almost 20 years or so. And what I have highlighted there in that oval red circle is just the trend within in the United States in terms of the average phosphorus levels or the mean phosphorus levels. And those levels have steadily risen among in-center hemodialysis patients in the United States, particularly since the year 2013. And at present, the average in-center hemodialysis patient in the US has a serum phosphorus level of 5.6. In the Europe, for example, that average level currently is around 4.8, and in Japan, it is somewhere in between at around 5.3. So next slide, please. And this depiction is not specific to hemodialysis patients. In fact, similar data from the peritoneal dialysis population that the DOPS has analyzed has reported that approximately 75% of peritoneal dialysis patients in the United States also have mean serum phosphorus levels that are above 4.5 milligrams per deciliter. Next slide, please.
Just coming back to, I suppose, the different ways that we evaluate these serial assessments of phosphate levels and how are we reacting to them. And I think that's something that we all instinctively kind of we all grasp, but we can occasionally neglect, which is that serum phosphorus, that we draw on a monthly lab is a spot value. And I had a patient just last week who generally has a very excellent phosphorus, and she came in on the Monday and we checked her labs, and we were discussing it on Tuesday, and she had a very high phosphorus, and she turned to me and she was like, I was at Chuck E. Cheese with my grandkid, and that's why. And equally, we all floss our teeth when we go to the dentist. We have patients who will try to improve on the week that they do draw labs. So a spot potassium or a spot phosphorus is not necessarily accurate to what the patient is experiencing all of the time. And in the same way that if we rely on a sort of an individual glucose level, it's not going to give us as great as, as global a picture as an A1C is going to do in terms of how a patient's overall diabetic control. Phosphorus value, spot phosphorus value is not that useful. And as Sagar said, if we look at one draw, 40% of patients will be above range, but within a 6-month period, 70% of those patients are going to be out of range. So there are ways to get around this, to do serial measurements of phosphorus, because unfortunately we just don't have the equivalent of an A1C for measuring a patient's serum phosphorus. And so various different methods have been suggested, looking at time out of range percentage, looking at rolling averages over sort of 3 to 6 month periods, just a simple trend, looking at residual standard deviation, or looking at area under the curve and time spent out of range during a 6-month period. And this last one, area under the curve, looking at time spent out of range, that has a correlation, and it's been shown to correlate with cardiovascular mortality, with a hazard ratio of 1.26 for a AUC of less than 0 to 0.5, and 2 for those with above 2. Now, I think it's probably unrealistic for most of us. We can only aspire to sit down for each of our dialysis patients and carefully plot out the AUC for 6 months worth of phosphorus. But again, I think it is worth reminding everyone that, the trend is probably the more significant than what an individual spot value is doing for phosphorus. And now, Elizabeth, thank you so much for joining us today. And I'm going to turn the floor over to you for a little while just to ask you from a patient's perspective, what it's like navigating these phosphate goals, and how difficult or easy is it for you?
Thanks for having me. I've been on dialysis since 2014, and it's been a challenge. So it's been 10 years, and it's still a challenge day to day, month to month. Monitoring phosphorus and understanding phosphorus. Susan, I did want to say I liked that you pointed out, like, talking about your patient who came in to have her labs checked and her phosphorus happened to be high. She's like, well, I did go to Chuck E. Cheese this weekend with my grandkids, and my doctor would tell you I am one of those who I will tell her right off the bat, my labs are going to be terrible this month. I didn't do good with my binders. I didn't do good with my eating. I know my phosphorus is going to be high. And there have been other times where it was a surprise to me, like to go in and have high phosphorus and say, Dr. Singh, I don't know. I swear I took my binders. I swear I've been trying to watch what I eat. And I think that's one of the biggest frustrations with phosphorus is it can really be a surprise month to month what that lab value is going to be. Because phosphorus is not one of those things that's easily measured in your diet. Like when you eat, I can pick out, a can of soup, and I know how many calories, how much fat, how much sodium, how many carbohydrates. I can't tell you how much phosphorus is in something. I know that I can read the ingredients label, and if phosphate additives is high in that list, then I assume that is a high phosphorus food, but I can't tell you it has 100 milligrams or zero milligrams. And so it makes it really difficult to know how much I'm eating. So it can make knowing what you're going to get month to month just difficult. And the other thing, Brandon, that you touched on was, the current research, I think you said, shows the source of the phosphorus is something that we need to start looking at. And I have what I would call an old school dietitian. She just hands you the list and says, this is what you can eat, this is what you can't eat, and you have to follow these two lists. But then there are newer dietitians out there who look more at that research and say, okay, well, we know certain, the difference between organic and inorganic phosphorus. And we know that organic phosphorus is not going to be absorbed at the same rate as inorganic phosphorus. And so I think also working with the patients to understand, I would love to be able to say that every day all I eat is straight up fruits and vegetables, and I eat the right fruits and the right vegetables, and my phosphorus is always in range, and I don't need binders because I'm so good at my diet. But that's not really the reality for a dialysis patient. And so I think really working with patients to understand, okay, do you have a weakness for pizza? Okay, you do. How do we fit a little bit of pizza into your diet so that you don't feel, because you feel like when you're given a list that says you can only eat these foods and you have to avoid all these foods, it's very limiting, and it makes the diet following the diet very difficult. And I'm trying to see. That's kind of like from the patient perspective, I think. And it's also, I was trying to think, and I think that's on this question, I think that's all I've got on that.
There's an old nephrologist joke, which is that there's three things you can put in your mouth on a renal diet: a knife, a fork, and a spoon. But I just wanted to ask you before we move on what your experience of taking phosphorus binders is, and do you find that difficult? Because I know they're big tablets, and you have to take, often people have to take quite a lot of them.
Yeah, I've been on, I was counting last night, and I think I've been on 5, maybe 6 different binders over the last 14 years in various doses. And really the thing that actually finally got me, and I'm glad you asked me that, because I did mention, I did see this on the slide. One of the things which actually helped me get my phosphorus down and limit my binder intake is I switched from PD to home hemo. And that home hemo, I mean, my first month, I was too low on my phosphorus. And my doctor said, okay, you're too low. We got to work on that. So I went on PD. I went from taking one medication where I took 3 800-milligram pills, so 2,400 milligrams at every meal. So I was taking 9 pills a day, and they're big. And I would tell my doctor, I'm like, I didn't take as many this month. I can't. I was worn out, and it was just too much. And so, and I've tried the pills. I've tried ones that you crush up. I've tried ones that dissolve in water. I mean, it's just, and I think patients and doctors have to have that open communication about each month saying, this pill is not working for me. What else can we try? And I think it's just a constant, you have to have that constant open communication, because I've had nurses tell me, well, all my patients take this. Okay, well, whatever this patient's taking is not working for me. And so just having that, and it gets frustrating because I'm a rule follower. And so when my labs come back and I'm like, I get really stressed out. Like, I don't know why my phosphorus is high, but so for me, it's been a little stressful just because it's always like a constant guessing game of what's going to work. But since I switched to home hemo about 1.5 years ago, I'm down to 1 pill with Mills, and that makes it much easier to be a compliant patient with my binders.
I imagine so. Certainly, I think it's the medication people want to come off the most. And certainly, my experience as a doctor is that if you can get rid of them, patients tend to be pleased.
Yeah.
So thank you very much for your insight on that. And what we might do now is just move on and talk a little bit about how hyperphosphatemia management has evolved over time. And Brandon, I might throw that back over to you.
Yeah, so I might recruit Elizabeth to do my talk here because she's done a lot of the work for me. And so as I was thinking about this question, I wanted to zoom out and think about the phosphorus balance and this idea of anytime I think about concentrations of something, physiological concentrations, it's kind of this balance between in and out. And so in people on dialysis, we have somewhat limited capacity to increase the out. And so oftentimes patients, dialysis and these medications aren't enough. And so phosphorus starts to build up. And so for that reason, there's been a lot of interest in limiting dietary intake of phosphorus. And so if I can advance to my next slide here. And the renal diet has undergone a lot of changes over the years, and we're somewhat in the midst of a paradigm shift. And so for majority of the recent history, we've had this era that's been dominated by an overall phosphorus restriction, typically thinking about foods in terms of the phosphorus per serving, and if there's a high amount of phosphorus, restricting those. And also trying to limit to overall quantitative targets. It's only in the last 20 or 25 years where we've really had this shift where we've started to think more seriously and focus more on some of the other factors, some of these qualitative factors like bioaccessibility that Elizabeth just mentioned. And so if I can advance to my next slide. And so in these last 20 or 25 years, really a lot of tools have been developed or become popular to help manage hyperphosphatemia. Even when we think about foods that are high in phosphorus, there's been somewhat of a shift from thinking about high phosphorus foods being in terms of milligram per serving to thinking about them in terms of milligram per calorie, this idea of phosphorus energy, because calories are more closely tied to overall intake over the course of a day. In dialysis, we also have this juxtaposition between these higher protein needs and this desire to limit phosphorus. And so we have this phosphorus to protein ratio that we'll sometimes use. And if I can advance to my next slide. We have, again, some other tools as well. So things like protein source have become, not this one, a focus in recent years, as well as things like culinary techniques. If I could go to the previous slide again. Culinary techniques and focusing on the phosphorus label as well. One of the most recent tools is phosphatemic index, which is akin to the glycemic index and measuring that area under the curve at a meal. But the one that's made it into the guidelines, if I can now go to the next slide, is bioaccessibility. And when we think about applying bioaccessibility, in practice, it's generally come down to these qualitative charts like this, where we think about plant-based foods having lower bioaccessibility than animal-based foods, which have lower bioaccessibility than phosphorus-containing additives. And while this is probably a pretty good rule of thumb, we're really still in our infancy of understanding bioaccessibility of phosphorus. And there is a lot of variability even within the same food items. And so some of the things that can influence phosphorus bioaccessibility include food processing, things like heat and moisture, hydrolyzed phosphorus from phytate, which can increase its accessibility. And as we enter this era of sort of functional foods, we see more and more foods that are fermented. Fermentation and germination and also increase phosphorus bioaccessibility. And so I think it's important to realize that while this is maybe a good general rule of thumb, that is probably a bit more complicated than that. And to throw one more item, when we talk about bioaccessibility, we're generally really thinking about bioavailability. And so most of this data, it's important to remember, is coming from in vitro accessibility studies where we digest foods in a test tube and see how much mineral we recover. And so if I can advance to my next slide, I point all of this out to show that, we have a lot of different ways of thinking about managing hyperphosphatemia. And when we try to incorporate those into patient-facing education materials, like those lists of foods that are high and low in phosphorus, we see a lot of inconsistency in the advice that we're giving. And so this is the results of a recent systematic review that we did with David St. Jules out in Nevada, Reno, where we searched the internet for patient-facing resources. A lot of these are foods of high and, to avoid and restrict or to encourage in phosphorus. And what we found is that there's a lot of inconsistency in these foods. We see a lot of inconsistency in animal protein as well as in whole grains. And what we also see is that a lot of foods we traditionally think of as being heart healthy, things like legumes, nuts, seeds, and whole grains, are primarily being restricted. And so potentially there are some opportunities in this area to get a more uniform and consistent message. If I can advance to my next slide here, just like there's been a shift in the renal diet over years, we've also seen changes in phosphorus medications. So they've also evolved. Starting with if we go back to aluminum and calcium-based binders that we saw specifically mentioned in the guidelines earlier, to more recent binders, and now to what really the topic of today is those phosphate absorption inhibitors.
So that sounds very, very challenging for any to navigate. Well, with sort of the challenges and also the sort of various information that's out there and often conflicting information. So I guess since we have kind of reached now let's talk a little bit about these new drugs, and Sagar, I'm calling you just to talk us through the mechanism of action of phosphate absorption inhibitors and how are they different from the traditional phosphate binder as we would understand it.
Sure, we'll be happy to. And just to follow up on what Brandon was saying, phosphate control typically requires a multimodal approach in a dialysis patient. So very likely there is not going to be just like a one pill or a one strategy that is going to be sufficient or well received by an individual patient. So a lot of effort is typically, dedicated by multiple team members, physicians, nurses, dietitians to get patients to the optimal phosphate levels. But at the same time, I think it is really exciting that we have a new drug approved from a class known as phosphate absorption inhibitor. And what I have depicted on this particular slide are the cartoons that distinguish the different mechanisms of action, particularly comparison between a phosphate binding on the left side in panel A and then the phosphate absorption inhibitors in panel B. So phosphate binders, as the name suggests, these are agents that are going to be essentially taken typically with the meals, and they will bind the dietary phosphate available in the intestine and block its absorption and just promote its fecal excretion. But as you can imagine, this is not going to be a very effective strategy if there is a lot of dietary phosphate coming in, for example, unless you are able to increase the pill burden substantially. And even despite having a significant pill burden, you may not be able to get all the phosphate under control. But what is now more appreciated is, are the pathways about the phosphate absorption. And I will get to the next slide here. Thank you, which kind of essentially nicely delineates the pathway for tenapanor, which is a recently FDA-approved drug to treat hyperphosphatemia among dialysis patients. And so the idea here is a lot of phosphate absorption is taking place through these paracellular pathways, so the channels or the spaces that are in between the adjacent intestinal lining cells, and that absorption is very tightly regulated by the help of different channels and different enzymes. And one of the key players in this mechanism is the sodium hydrogen ion exchanger, abbreviated here as NHE3. And by changing or rather modulating the sodium hydrogen ion exchanger, you can actually either increase or decrease the absorption of the phosphate that will take place through this paracellular spaces that are available in the intestine. So what tenapanor is known to do is, in fact, it because of its actions on this sodium hydrogen ion exchanger, it will essentially close that space between the enterocytes, so that way absorption of the phosphate will not take place. And as you can imagine, this mechanism allows the intake of the drug even outside the intake of the food. So this does not have to be necessarily timed with the intake of the meals. Tenapanor is also otherwise approved for another indication outside of the dialysis setting, which is the irritable bowel syndrome. And collective experience of this drug from both these settings has shown us that there is very little to no absorption, systemic absorption of the drug. The protein binding level is around 99%. Metabolism is predominantly hepatic via one of the CYP pathways, and it is metabolized into its inactive metabolite, and the excretion is predominantly into feces. Next slide.
It sounds very exciting to have a drug with a novel mechanism of action, but what do we know about the safety of the drug?
Yeah, no, that is such an important question, because of course, efficacy and safety are important for all patient populations, but particularly as all of us take care of individuals who are on dialysis, we appreciate how important it is, particularly to understand the safety and the pill burden and other aspects when it comes to any new drug entity. So tenapanor has undergone, multiple clinical trials for the indication of hyperphosphatemia. Because of the limited time we have, I won't get into all the trials, but I will hopefully share with you high-level information from some of the main trials that resulted in the approval of the tenapanor for this indication. So this is a study that you see on your slide, is a study of approximately 220 dialysis patients. They were recruited from 41 United States sites, and the investigators assigned these patients to broadly to two groups, either tenapanor group or the placebo group. But within the tenapanor group, there were 3 different doses that were tried: 3 milligram twice a day, 10 milligram twice a day, or 30 milligram twice a day. As you can see in this visual abstract, the change in serum phosphate is their primary endpoint. And across all the 3 groups of active intervention with tenapanor, you see on average anywhere between 1.05 to 1.09 milligram per deciliter reduction in the serum phosphate. And this was, of course, statistically significantly different compared to the placebo group, which in fact did show 0.79 milligram per deciliter increase in the level of serum phosphate. Now the dose, in terms of the different doses, clearly there seems to be more effect with the higher dose, which was the 30 milligram BID, and that's the dose that has been then subsequently studied in other clinical trials. So next slide, please. So this is one of the main trials, again known as Amplify trial, and the study design is a bit complex, but let's try to understand it with a little bit more granularity. So in this trial, again, they are looking at chronic dialysis patients. They are screened on average anywhere between 2 to 4 weeks before the trial intervention begins. They have very specific eligibility criteria, and a number of patients, in fact, close to 50% or so, were excluded because they did not meet those predetermined thresholds for either phosphate or some other clinical characteristics. Subsequent to the determining of the eligibility, then the patients are randomized into different groups. Either they get tenapanor with phosphate binder, or they get placebo with phosphate binder. And they recruited around 120 patients in both of these groups. The primary endpoint that was studied is the change from baseline in serum phosphorus at week 4. So next slide. And so in this study that is published in JASN in 2021, led by Dr. Pargola, what you can see on this slide is the reduction in serum phosphorus is much more robust in the group that received tenapanor plus phosphate binder compared to the group that received placebo and phosphate binder. On average, that reduction was around 0.84 milligram per deciliter. Next slide. And you also see that the proportion of patients who achieved that therapeutic goal, for example, of serum phosphate of below 5.5, and you can see a nice separation between the 2 intervention groups. The solid circles and the solid black line represents the tenapanor arm, and then the gray circles and the gray line represents the placebo group. So you can see at all the study time points, week 1, week 2, week 3, and week 4, the proportion of patients who were below 5.5 was much higher in the active intervention group. Next slide, please. Interestingly, the investigators also did look into some of the other novel markers of mineral metabolism, and one of them is shown on this slide, known as FGF23. And again, there is a clear signal supportive of more reduction in the levels of FGF23 in the group that received tenapanor compared to the group that received placebo. Next slide. Going back to some of the additional trials, this is a Freedom trial. This is another phase 3 study that was designed to understand both the efficacy and the safety of tenapanor. But unlike some of the previous trials that I showed you, here the follow-up is longer, all the way the study intervention, first of all, is for 26 weeks, which is a randomized treatment period. And then there is a randomized withdrawal period of 12 weeks. And then the safety extension period beyond that of 14 weeks. So now we are seeing a little bit more longer experience from the clinical trial setting regarding the use of tenapanor. Again, this study also had two arms, tenapanor arm that recruited 423 patients and a sevelamer group that recruited 141 patients. The primary efficacy endpoint here is the difference in the change in the serum phosphate from the end of the randomized treatment period to the end of the randomized withdrawal period. So in the middle of that slide, if you can see my arrow, is post-randomization withdrawal, and that's where they studied their primary efficacy endpoint. Without getting into all the details about the study regarding its efficacy, it suffices to say at a high level, the study was positive in terms of its efficacy, and on average, there was a difference of 1.4 milligram per deciliter in favor of tenapanor compared to the sevelamer group. Next slide, please. This is another phase 3 study. Now, this is conducted outside the US in Japanese hemodialysis patient population. 40 centers were part of this study, and again, this was focused on dialysis patients with end-stage kidney disease. Patients had uncontrolled hyperphosphatemia despite taking the phosphate-binding medications. They were assigned to either tenapanor or placebo. And again, as you can see here in the outcomes column, in the middle of this visual abstract, you see on average around 2 milligram per deciliter reduction in serum phosphorus with the tenapanor treatment. The adverse events, and I will of course give you a summary slide that looks into the adverse events from all of these trials as a totality of the evidence. But in this particular trial, around 63% of the participants reported diarrhea as the adverse event, and overwhelming majority of those events, 75% or so, had mild diarrhea. And the diarrhea rate when the placebo group was much, much lower, approximately 14% in comparison to the 63% that was seen in the tenapanor group. Next slide, please. This is another trial that is looking at not so much efficacy in terms of the phosphate control, which of course is important, but now I have shown you a number of studies that demonstrate its efficacy. But this one also looks at a pill or effect of this agent tenapanor on the pill burden. And if you focus your attention to the right side of this visual abstract, in the middle part, where we describe the mean total number of daily phosphate binder tablets, there was a substantial reduction from average pill burden of around 15 pills per day at baseline to now down to around 3 pills at the 26-week follow-up. So that was quite striking to me, considering how pill burden can be important for our dialysis patients. Next slide. And so just briefly mention the safety and the tolerability issues, as was reported in one of the Japanese trials, and this is consistent with other trials of tenapanor also, including those that recruited patients in the United States. Diarrhea is a common adverse reaction reported by anywhere between 40 to 53% of the trial participants. Majority of the events by the trial participants were mild or moderate in severity and resolved over time or with dose reduction. Severe diarrhea was reported in around 5%, and in less than 1% of the patients, it was associated with dehydration or hyponatremia. Diarrhea can typically start soon after its initiation, but can occur at any time. Treatment should be discontinued in patients who develop severe diarrhea. And of course, as you are starting patients on this drug, if they're already taking agents like stool softeners or laxatives, then those doses need to be adjusted or stopped. And then the patient should be counseled not to take tenapanor right before a dialysis session and to take tenapanor right before the meal, as some patients may experience diarrhea after taking the tenapanor. Next slide. And just quickly, there are some drug interactions to be aware of, particularly with enalapril. The dose of enalapril may need to be lowered because of the interaction with the OATPB to be 1 substrate. And also, if the patient is also on sodium polystyrone, then the doses need to be separated by at least 3 hours.
And so Sagar has covered a lot of what I was going to talk about, but just wanted to, again, what are the primary education points that we should talk about before starting on these medications, and how are they different from the phosphate binders? And again, you know, if you're administering tenapanor, firstly, it's important to know that this is only licensed for patients with end-stage kidney disease, not licensed for CKD. But it's important to stress to them that it is different to a phosphorus binder, and it has to be taken differently. It's given twice a day, before the first meal of the day and after the last meal of the day. And if a dose is missed, then they should just go ahead and they should skip that dose. And you know, when you're approaching these things to patients, I think there are pros to the medication, and it has an alternate mechanism of action. It's a smaller tablet, has a smaller pill burden than our phosphate binders, which can often take up like 50% of our pill burden, as Elizabeth was talking about. And for some patients, it may bring constipation relief. So I had a patient recently who I talked to him about the diarrhea, and he was like, "That's great, sounds perfect to me," because he was so persistently constipated. It does still add to your pill burden. It adds 2 additional meals a day, or 2 additional tablets a day. It does need to be taken with meals, and there is this issue with diarrhea. And when it comes to diarrhea, I think it's important to warn patients about this risk of loose stools, and that it was present in 50%. And, you know, while a very small amount of the patients had severe diarrhea, what we may consider severe diarrhea and what a patient may consider severe diarrhea, it can be different. And just to make sure to avoid the co-administration of laxatives. And again, the manufacturers suggest avoiding to take prior to dialysis. Presumably that means if you're going on a long car drive, or you're going to see Doom 2, you probably shouldn't take it anywhere. You need to have kind of ready access to a bathroom. And when counseling people about diarrhea and how likely they are to get diarrhea, the majority of this tends to come on very early in the course of trying this medication. So, you know, usually in the first 1 to 8 days, tends to taper off. But there are still people who, after 15 to 22 days, after 22 days, will still present for the first time with diarrhea. And again, it is a very common side effect, so you need to counsel your patients about that. It does tend to taper out over time, and people tend to adjust to it and find it not as big a problem as they have been on the drug for a couple of weeks. So how do we go about approaching starting this agent for a patient? So remember, indications, it's indicated for those with serum phosphorus in adults with chronic kidney disease. It's contraindicated in those less than 6, and it's known those with suspected or mechanical gastrointestinal obstruction. Dosage starts out at 30 milligrams orally. Available strengths are 10, 20, and 30 milligrams, but the recommendation is to start at 30 milligrams. And we might just skip over this for in the sake of time. We might just move on to the next slide. And talk a little bit about access and affordability. Prior authorization right now is going to be required for all patients on this medication. It is only available for a limited number of specialty pharmacies, the partner pharmacies, and several other network pharmacies. If the patient does not have affordable access, Ardelyx Assist is available. There is a patient support program for eligible patients, and they need to verify insurance coverage, support reimbursement related activities, and provide copay assistance. Copay cards are available, and there is a letter of medical necessity template, and we have a little just for more information to visit their website. So before we get to our Q&A, Elizabeth, I might just turn it over to you again and ask, as a person with experience managing your own hyperphosphatemia, how do you think this is going to impact maybe not you, but perhaps other patients?
As we've already discussed about the size of the pill, the timing of the pill, not having to take as many pills, that would be, I think, the biggest impact, because as I mentioned before, it just becomes so cumbersome when you have to take so many pills. And the idea of taking a pill, like with my first meal in the morning and my last meal at night, and that's it, and it's a smaller pill. The other thing, especially with the pills that I take now, when I was having to take 3 of them, they're so big. And the thing is, for me personally, I had to drink so much liquid to get each pill down that it was really kind of a challenge. I would constantly tell my doctor, I'm like, look, I can eat, I can drink, or I can take some binders. But to do all 3 hurts my stomach and it's too much. And so the idea of taking a smaller pill, not having to take as many pills, that would be one of the biggest pros to me. And the other thing, Susan, that you mentioned is, for some patients, the diarrhea might be a relief because they're constipated. And that's one of the things that I found with so many of the different binders that I've taken, is that constipation. And so I'm not saying that diarrhea would be great, but you know, you kind of pick one or the other, and you know,
a happy medium.
Yeah. And to me, I think, you know, I find maybe sometimes it's easier to maybe manage the diarrhea a little bit better. And I think that's really the other point that I also thought might be good about one of these inhibitors like this is, from what I understand, is the pill becomes more of like part of your regular pill routine, like taking your blood pressure medicine, taking like I take Eliquis for blood clots. It becomes more of that regular pill routine. And whereas with the binders, and I mean, and this sounds ridiculous, but I would take my pill binder, or my binder bottle, like if I went out to eat, and I could sit it on the table at the restaurant and I can still forget to take it.
Mm-hmm.
So, you know, having something that becomes more of a regular pill routine, or I'm already taking these other pills once or twice a day, rather than having to remember to take 9 pills throughout the day, I think would definitely be a benefit to a lot of patients.
So it kind of slots more easily into what you're doing for most of your other medications.
Yes, yes.
Okay, so thank you so much for that. And now we're just going to move on to the Q&A part of our topic. So thank you very much to all of our speakers, and thank you so much to all of you who submitted the questions. So we're going to just go through a few of the questions that you submitted. So what we might start, the first question we might start for, and this is, do we have any data on how effective the phosphate absorption inhibitor is for patients on enteral nutrition? And Sagar, is that something that you know about from the studies?
It's a great question. To the best of my knowledge, there is no data at this point in terms of patients, you know, who are on other nutritional therapies like enteral nutrition, for example.
Great. And what about other essential nutrients? Do we know how this medication affects them? Has that been looked at? And is there any risk of hypophosphatemia? It didn't seem to be reported in any of the studies as a major negative effect. Yeah,
so again, you know, to the best of my knowledge, you are right, Susan, the hypophosphatemia has not been a concern in center patients. Now, of course, things could be different in other types of dialytic modalities. And the other nutrient data also, I think this will have to be closely followed up to see whether, if at all, if there's any deleterious or other impacts on the other nutrients. But to the best of my knowledge, the data thus far have not either studied that or have not shown any impact on those parameters.
Okay. So our third question is about the timing of administration and what to do in terms of when to take it, and what about if people don't eat breakfast? And I think in terms of, it should be taken twice a day, early in the morning and late at night, ideally. in terms of why with food, my understanding that comes really from looking at the sort of irritable bowel syndrome data, and that seems to suggest that patients who took it without, that their diarrhea could be worse, that they could have more, just feel less well on it. So in terms of what to do if you don't eat breakfast, I think that could be a challenging one. And then there's a question about pediatric patients. So and whether there've been any trials for pediatric patients. I'm not aware of any pediatric trials. I think that they have all been conducted in adults so far in terms of our phosphate binder trials, and we know that if you're less than 6, that is a contraindication to taking the medication. So are you aware of any trials going on in the pediatric population?
I'm not aware of any for pediatric population.
Okay. And then I think the next question, Sagar, was about your slide, particularly about your slide showing the actual mechanism of the inhibitor. And your slide showed nicotinamide as well as being a phosphate absorption inhibitor. And how is that mechanism of action differ from that of tenapanor?
Sure. So the tenapanor, as we discussed, is the specific target here is the sodium hydrogen ion exchanger. For nicotinamide, it is the NaPi2b target for blocking the absorption of phosphate. And nicotinamide, although biologically speaking, pharmacologically speaking, seems to be very promising approach. A recent trial conducted by Joe X and Tamara Isakova did not confirm its effect as a phosphate lowering agent. So even though the mechanism seems to be attractive in terms of blocking the phosphate absorption, the clinical trial data does not support, and we are still trying to actually understand why that is not effective as a phosphate lowering agent.
Great, thank you very much. And I think this will probably be our last question, but just a question from the chat. Can patients take loperamide to manage the diarrhea symptoms? And that honestly is an answer I don't know. My understanding is that and again, this is looking at a lot of the IBS literature, so it's not necessarily all that relevant to this literature because it's a lower dose, but that it can be the diarrhea when it comes can be quite forceful. And so that whether loperamide is going to be helpful for managing those symptoms, I don't know. All right, guys, we're pretty much at the end of our hour. So we really appreciate everybody coming to listen in, and we're really appreciative of all our speakers. Thank you so much for coming and taking the time to talk to us in your various guises. And also thank you to Andrew, who was our captain and who organized this and put this all together and did sterling work in putting together our slides. And thank you to the NKF for inviting us all today to come and talk. So again, there is a survey to complete if you would be so willing to just give us a little bit of feedback. That always helps us improve our content. So the link is in the chat if anyone wants to click on it, or alternatively it's going to come up via email. We've also included a link to our Life as a Nephrology Professional podcast, which is also in the chat. And we just released 2 episodes on hyperphosphatemia and phosphate absorption inhibitors. And we would be very grateful if you check those out. So once again, thank you everybody for being involved, and we'll see you again.